Hypoplastic left heart syndrome. A single ventricle, the most severe form of congenital heart disease characterized by only one usable ventricle, and the final common pathway of the Fontan's procedure. The surgical palliation that relies on the downhill flow from the veins to pulmonary arteries with no pump to the lung. Its long-term complications are numerous. Tricuspid atresia and hypoplastic left heart syndrome are most common varieties. So hypoplastic left heart syndrome denotes the continuum of the congenital heart defect that are characterized by underdevelopment of systemic ventricle and occurs in combination with abnormalities of the aorta, aortic valve, and mitral valve. It accounts for 3 to 4% of the congenital heart defect and responsible for 25% of the cardiac deaths in first week of life. The left-sided cardiac structures are inadequately developed to support the systemic circulation, placing the work on both pulmonary and systemic circulation solely on the RV. The left to right shunting in the atrial level allows the pulmonary venous return to enter the RA, and right to left shunting through the enlarged patent ductus arteriosus allows systemic perfusion. Retrograde flow to the arch and the ascending aorta provides the majority of the cerebral and coronary blood flow because of the inability of the left heart to support the systemic circulation and perfusion. This condition is ductal dependent lesion and requires the atrial level shunt of ASD for adequate mixing and oxygenation of the oxygenated blood. Cyanosis, CHF, and systemic hypoperfusion results in peripheral vascular resistance decrease and pulmonary flow increases at the expense of the systemic blood flow in the first week of life. There are 4 morphological types can be defined: aortic and mitral atresia, aortic atresia with mitral stenosis, aortic and mitral stenosis, and aortic stenosis with mitral atresia. Aortic atresia and mitral atresia is the most common variety, whereas aortic stenosis and mitral atresia is the least common but highest risk subtype. Patients with aortic stenosis and mitral stenosis may be considered for biventricular repair depending on the valvular and LV development. Otherwise, they are treated with a single ventricle stage palliation and other variants. Varying degree of endocardial fibroelastosis are seen within the LV, and the RV is enlarged with uniform hypertrophy and increase in the size to approximately 3 times the normal. The main PA trunk is the large and continues directly into the large PDA. The infant of this condition unborn at gestation and may appear normal at birth or present with mild cyanosis, tachypnea, tachycardia, while the neonatal circulation supports the child. The echocardiography is diagnostic. The decrease in the peripheral vascular resistance and the initial overcirculation of the pulmonary vasculature, but eventually leads to cyanosis and failure of the PO intake and congestive heart failure. Ductal closure results in the rapid circulatory collapse, shock, and death without immediate intervention. In 10% of the patient, the intact restrictive atrial septum or diminutive closed PDA will require the urgent intervention to establish the appropriate mixing of the blood and reserve the perfusion to the newborn. The extracardiac malformation or genetic disorders occurs in 10 to 28% of the patient. A single S2 and left parasternal murmur and LV lift can be appreciated on the physical exam. The ECG reveals RA enlargement with RV hypertrophy. Chest X-ray reveals cardiomegaly with increased pulmonary vascular marking, and echocardiography allows a definitive diagnosis and detailed characterization of the involvement of the structures. Although it is clinically silent in utero, the prenatal diagnosis increasingly and frequently due to the advent of the fetal ultrasound and the absence of the normal 4-chamber heart on the ultrasonography leads to further evaluation. Pulmonary atresia with intact ventricular septum can undergo 2 ventricular repair if RV is enlarged enough and coronary arteries are dependent on the high pressure of RV. These are very small RV and RV developmental coronary circulation and may require Fontan palliation. Other forms of single ventricle is double inlet single left ventricle, unbalanced AV canal, primitive heart with a single atrium and ventricle. Hypoplastic left heart was historically considered a non-survivable lesion, and the treatment involved the supportive care and until death. Modern structured therapy now includes the stage palliation of the univentricular circulation or the cardiac transplantation. If considered for transplantation, the procedure is to stent the ductus arteriosus or enlarge the intra-atrial communication may be required. Patient with a borderline left heart function may be considered for the biventricular repair through the primary correction of the involved cardiac lesion. The fetal aortic valvuloplasty has been performed in the features of the aortic stenosis and evolving hypoplastic left heart may increase the likelihood of biventricular repair. At birth, the infant requires the infusion of the prostaglandin E to maintain the ductal patency. Urgent balloon septostomy or surgery is required in patients with intact ventricular restrictive atrial communication to allow the left heart shunting and the systemic flow via the PDA. Adequate balance with the pulmonary and systemic blood flow must be maintained by altering the pulmonary and systemic vascular resistance and low inspired oxygen concentration. The addition of the carbon dioxide to the inspired gas is effective in raising the pulmonary vascular resistance in response to the pulmonary circulation in the systemic hyperperfusion. Alternatively, alpha adrenergic agonist and antagonist can be used to augment the SVR to optimize the QPQS and systemic oxygen delivery. The stage palliation is done by the Norwood operation for the infant selected for single ventricle palliation. The high neonatal pulmonary vascular resistance prohibits the immediate Fontan procedure. Instead, a three-stage sequence is utilized to accommodate the changes of pulmonary vascular resistance. Stage 1 construction is performed shortly after birth via median sternotomy and either a deep hypothermic circulatory arrest or antegrade cerebral perfusion and a moderate hypothermia depending on the center's preference. Three primary objectives of the Norwood procedure are unobstructed systemic and coronary arterial blood flow, a stable and balanced source of pulmonary blood flow, unobstructed pulmonary venous return to the systemic RV. These goals can be achieved by three techniques: performing the atrial septectomy, construction of the new aorta for the pulmonary trunk by dividing the main PA at the bifurcation and then anastomosing it to proximal aorta, placement of the systemic to pulmonary shunt, typically either by a modified Blalock Taussig shunt or RVPA conduit, a Sono shunt. The modified BT shunt uses the interposition graft between the right subclavian and innominate artery in the right PA, and more recently the RV to PA shunt Sano modification have been used to the source of pulmonary blood flow and are thought to improve the coronary perfusion by reducing the systemic runoff into the pulmonary circulation and the coronary steal that occurs when the aortopulmonary shunts are placed distal to the pulmonic valve. The landmark single ventricle reconstruction trial randomized these patients to receive a modified BT shunt or RVPA conduit. So after the results are equivalent and both the shunts are used. At the specialized central hospital, the survival after the stage 1 reconstruction and the survival to stage 2 operation can be approached to 90 and 80% respectively. Post-operative management of the patient after a single first stage reconstruction is difficult since these patients tend to be very hemodynamically labile. The cardiovascular system after the stage 1 consists of the parallel circulations that are compelling with each other in terms of the blood flow. The balance between both circulation depends on the pulmonary and systemic vascular resistance, and the amount of flow into the circulation being inversely proportional to its vascular resistance. The PVR can be modified by changing the FiO2 along the hypercapnia or administering the inspired CO2. Hypoxia and hypercapnia increases the pulmonary vascular resistance and therefore increases the systemic blood flow. Similar SVR can be controlled pharmacologically and using the alpha-adrenergic agonist and antagonist. The goal is to provide the adequate blood supply to both circulation. The ductal stenting with the bilateral PA banding deemed hybrid procedure has such been employed at some centers for the high-risk neonates to achieve the stage 1 palliation with or without early morbidity and cardiopulmonary bypass and deep hypothermic circulatory arrest. Either an interval stage 1 or later comprehensive stage 2 procedure 3 to 6 months of age is then performed, at which time the new aorta and the bidirectional cavopulmonary shunts are constructed. The disadvantages of the hybrid procedure include the unrepaired hyperplastic aortic arch, which carries the risk of the cerebral coronary malperfusion due to the retrograde arch obstruction, restrictive intraatrial communication, and requiring the intervention of mechanical distortion of the branch PAs, and the greater surgical requirement during the stage 2 palliation of the interval stage is not performed. The second stage palliation of the bidirectional gland or hemifontan, the second stage procedure is performed between 2 to 6 months of age and aim to reduce the volume load of the RV once the PVR has fallen sufficiently to accommodate the passive venous return to the pulmonary circulation. For the gland, the systemic and the pulmonary circulations are partially divided by performing the bidirectional cavopulmonary anastomosis, and the PA may augment and prevent against the stenosis. The SVC is divided and anastomosed end to side to the right PA, or the prior BT shunt is taken down. The hospital survival after the stage 2 reconstruction approaches 95%. The complications are rare. Stenosis of the cavopulmonary anastomosis may occur, causing phase of bilateral upper extremity edema. The hemifontan is an alternative utilizing anastomosis between the PA SVC RA junction, therefore the augmenting of the PA as a part of reconstruction and possibly improving the hemodynamics. There have been no differences in mortality between the two techniques, but the hemifontan is more technically demanding procedure, and some reports indicate the increased risk of arrhythmias. The stage 3 palliation of the Fontan's operation. The Fontan's operation is performed at 2 to 4 years of age and entails a redirecting of the IVC flow through PA-SVC confluence to complete the division of the pulmonary and systemic circulations. The RV is relieved of systemic venous return, allowing the pressure of the volume offloading of the ventricle and improved oxygenation from abolishment of the right ventricle shunting. The two common techniques for Fontan constructions are the lateral atrial tunnel and the extracardiac interposition graft, and the lateral atrial tunnel uses an intra-atrial patch at the partition of the right atrium to reroute the IVC flow and the PA-SVC confluence. This operation leads to a higher rate of post-operative arrhythmias due to the presence of the atrial suture line, and the lateral tunnel Fontan is commonly performed following the hemi-Fontan procedure. The extracardiac Fontan uses a tube graft sewn directly to IVC to the intersurface of RPA, and this provides a simpler operation with reduced post-operative arrhythmias. However, shortcomings include thrombogenicity and the lack of the growth potential. A fenestration or communication between the intra-atrial and the tunnel and interposition graft and the RA can be created to serve as a residual right-to-left shunt. Modification is intended to decompress the high pulmonary pressures in setting of the transient increase in postoperative PVR. Fenestration may be closed effectively at a later date by transvenous catheterization, and the hospital survival for these patients are around 98%. So the complications are arrhythmias and ventricular dysfunctions, and sudden cardiac death can also happen in children. The long-term complication of the stage palliation of the Fontan sequence for this condition include the protein losing enteropathy, plastic bronchitis, thromboembolism, arrhythmias, heart failure requiring reintervention or retransplantation, a sudden cardiac death with current advance in surgical and critical management. Patient undergoing the stage palliation experience a 65 to 70% survival at the 5 years in modern era. In recent institution series, the analysis of the patient achieving the Fontane's completion demonstrate excellent 90% 10-year survival. Thank you.